This session covers the best ways to integrate a pharmacist into your practice, viewing the pharmacist as an extension of primary care instead of a threat, and my personal vision for the role of the pharmacist in 2050. Clinical pharmacists are uniquely capable of collaborating with primary care physicians to relieve their heavy workload and help improve care for a wide variety of patients. They have your back. If you're fortunate enough to have a clinical pharmacist on your team, learn their strengths, leverage their skills, and promote similar collaborations to what we've discussed throughout this course. To get started, some options for collaborations include employing a clinical pharmacist whose time can be shared by the physicians in your group, contracting with a clinical pharmacist in the community, or partnering with a nearby school of pharmacy. If you have not yet worked with a clinical pharmacist at all, a good place to begin is referring at-risk patients to them for medication safety reviews. Clinical pharmacists can improve patient safety by simplifying those complex medication regimens, reducing drug loads in polypharmacy situations, and minimizing vulnerable patients' exposure to high-risk medications. You could refer to clinical pharmacists on an ad hoc basis or direct them to consult with all patients who meet specific criteria, such as those who use more than 10 prescriptions or those who are on a specific dangerous medication. For some drugs, temporary side effects can cause patients to give up on therapeutic plans before the benefits occur. Metformin, oral and topical acne medications, and SSRIs are examples of drugs that are typically tolerable in the long run, but can have rocky starts. Early side effects and late arriving benefits can discourage the patients to give up on their plan. The clinical pharmacist can check in with the patient during the first weeks of treatment, reassure them that the side effects are likely short-term, and reinforce the overall treatment goals. This can help reconnect with the patients who have not kept an appointment in years by contacting those who are past due for evaluations or whose prescriptions have lapsed. These connections can also help reduce patient attrition, which often goes unnoticed in busy practices, lend insight into your actual patient panel size, and unearth reversible trends that lead patients to quit care. As confidence in your team approach grows, you can extend your collaborations into more complex areas such as drug monitoring, chronic care management, deprescribing, and population health. One dilemma that doesn't seem to get easier despite its frequency is deciding whether, when, and how to start or stop anticoagulation therapy. These high-stake decisions must be individualized and deserve a full review with the active patient or caregiver engagement. Clinical pharmacists can formalize the approach to these cases and often lead these. Some drugs need frequent monitoring that can be crowded out by the competing demands of a medical practice. For example, amiodarone requires regular thyroid assessments that the patient's cardiologist may not be monitoring if the patient still has a cardiologist. Oral antifungal drugs and naltrexone require monthly hepatic evaluations. You may have inherited treatment plans from other doctors that include testosterone, lithium, or anti-seizure medications. Are you confident that all your at-risk patients, are up to date? Clinical pharmacists can check lab results, order missing tests according to your provisions in your CPA, and intervene when results are concerning. Clinical pharmacists also watch out for over-the-counter drugs. For example, if a patient is using an NSAID and has not had a recent GFR check, the clinical pharmacist may order this to help prevent short-term renal damage and long-term disease progression. Patients with chronic conditions often need intensive interprofessional interventions to avoid poor outcomes. For example, patients with COPD who continue to smoke can lead to permanent damage, recurring hospitalizations, and extensive suffering that create huge expenses within health systems. Pharmacists who meet regularly with patients are well positioned to assess the severity of the disease and rates of progression and to escalate therapy as needed. They can also assure safe and effective use of inhalers and nebulizers, while at the same time prescribing and guiding treatments for nicotine dependence and smoking cessation. Chronic care management hinges on access to medications, especially for diseases like type 2 diabetes and COPD. but keeping up with the ever-shifting coverage rules for many drugs can use up all of your time with your patients. Clinical pharmacists can become the experts on these time-sensitive pieces of primary care by substituting lower-cost medications, matching medications within a drug class to updated formularies. Make sure your CPA allows in-class substitutions. Enrolling patients in alternative payment options and strategizing with patients about how to time their out-of-pocket costs. Pharmacists can be highly effective at deprescribing unhelpful or hazardous medications. Two areas of opportunity are called drug walkbacks and age-outs. Walkback candidates include daily dose medications for intermittent or cyclical conditions, furosemide for edema, proton pump inhibitors for gastroesophageal reflux, and SSRIs for depression, are all eligible for trials of tapering to discontinue with reintroduction if the symptoms recur. One common age-out medication is aspirin. Multiple studies have revealed its impotence at preventing heart disease in most age groups, yet it perseveres as one of the most frequently taken medications in older patients who are vulnerable to GI bleeding. Clinical pharmacists can spot those who have aged out of aspirin and save them from bleeding events. Similarly, the primary prevention benefits of statins decrease substantially in advanced age patients. The drug toxicity often becomes a bigger problem than the benefits. This makes them a reasonable candidate for deprescribing. In contrast to always being the first stop, like Canada's vision, I would prefer to think of pharmacies as an extension or a supplement to primary care, allowing patients a monthly maintenance touch point instead of the 0 to 4 times per year that patients typically receive primary care. In my current opinion, let the diagnosticians, like physicians and mid-levels, handle the particularly complex patients or illnesses. But pharmacists can handle the minor stuff, manage common chronic conditions, and escalate when necessary. Here's how I envision the ultimate role of pharmacists, maybe even by 2050. Patients are diagnosed with a new condition by a physician or a mid-level provider. The patient and new diagnosis are immediately handed off to a pharmacist to determine medication therapy if necessary. The pharmacist will have access to all of the patient's information, including medication history, vitals, labs, and other conditions. They discuss the patient's personal goals for therapy to make an appropriate decision for next steps. The pharmacist monitors and adjusts all medications over time based on remote patient monitoring and labs. Any pharmacist would be doing this for common chronic conditions like diabetes, hypertension, while specialized pharmacists could handle less common diseases like HIV or schizophrenia. For pharmacists, this is already within sight, practicing at the top of their license, making real impacts on patients, and taking the pressure off of primary care providers. They just need the opportunity. This session covered the best ways to integrate a pharmacist into your practice, viewing the pharmacist as an extension of primary care instead of a threat, and my personal vision for the role of the pharmacist in 2050.